Let's go ahead and cover anemias and everything you need to know about it for your Medsurg or adult health nursing course and for the NCLEX. Anemias is not my favorite topic, but I made it through it and so will you. Let's first understand the definition for anemias. Anemia is a state of decreased oxygen carrying capacity. Simple as that, where the body is not able to carry as much oxygen. There are three primary labs that we use to test for anemia, and we're in the first box that says background. Over here we see red blood cells, hemoglobin, and hematocrit. If any one of those are low, your patient is anemic. Let's go through each one of those. RBCs are red blood cells. These are produced in the bone marrow. The stimulation for the production of red blood cells, by the way, is called erythropoiesis. The stimulation for that is stimulated by erythropoietin. Erythropoietin is produced and secreted by the kidneys, and that stimulates red blood cell production. If a patient has erythrocytopenia, meaning they have a low red blood cells, then your patient's anemic. If your patient has an excess of red blood cells, which happens from a few different causes, such as living at high altitudes, your patient doesn't have anemia and is not part of today's discussion. Now, there's three basic ways that we break down anemia, and then we're going to keep talking about all the different labs here, but let's start with this. All of the anemias we're going to discuss today fall into one of three categories. The patient's anemic, again, that means low red blood cell and or low hemoglobin and or low hematocrit. A patient is anemic because of one of three reasons, either blood loss, such as GI bleed, such as excess vaginal bleeding, such as trauma. The patient has a problem with red blood cell production, which is the most common cause of anemia, and that includes iron deficiency anemia, folate deficiency anemia, B12 deficiency anemia, or the patient has a problem of red blood cell destruction, such as in sickle cell anemia. Again, all anemias come down to one of three problems: blood loss, decrease in red blood cell production, or an increase in red blood cell destruction. Now let's get back to it. Let's look at hemoglobin. Hemoglobin is an iron molecule that's within our red blood cells, and its job is to carry oxygen. The normal red blood cell number, and there's something called the rule of 5, 15, 45. I didn't make it up. I heard it from a cardiologist at University of Louisville, but it's the best thing that I heard to help me remember the numbers. A normal red blood cell is around 5. The normal lab on a hemoglobin is going to be around 15, and a normal hematocrit is around 45. The 5, 15, 45 rule. It's not perfect, but it definitely gets you in the right ballpark so that you know if you hear a hematocrit of, let's say, 20, you know that's way too low, or 50, you know that's high. Let's get back to it. Hemoglobin, again, is the iron molecule within a red blood cell that carries oxygen, and a normal hemoglobin, we just said, is around 15. A good number to know is that hemoglobins are the way that we evaluate whether a patient needs a transfusion. And the rule of thumb is we transfuse patients when they have hemoglobin less than 7. That's considered critical. And usually that's where we would go ahead and give the patient a transfusion. It could be anywhere from 6.5 to 7.5 and maybe a little bit higher depending on the patient, but that's a good rule of thumb that we use. So that's our hemoglobin, that's what it is, and that's how we use that number. Next, we have hematocrit. Again, I know you've heard all these stuff before. I just want to make sure you really understand it well. Hematocrit is actually a percentage. So normal hematocrit, we just said, is 45%. Females, it's a little lower. Males, it's closer to the 45. But a hematocrit is the percentage. In our blood, we have liquids and solids. We have solids like platelets, red blood cells, potassium, sodium, things like that. And then we have liquid. Obviously, we need to have the right balance. Our blood can't be too thick or else it'll clot. And we don't want our blood too watery because that means we're missing something in our blood. Hematocrit should be normally, let's say, 45%, 40 to 45%. And that means that it should be 40 to 45% solid. And the rest, the other 55% or so, should be liquid. And that's the right balance. That way our blood is not too thick and not too watery. Now, that's what the hematocrit checks. And if a patient has a low hematocrit, that means that the patient is missing some solids. Okay? So if a patient is missing some solids, we're going to say they're anemic and make the assumption that they're missing red blood cells. Now, can a patient have too high of a hematocrit? Yes. That can come from a patient, most commonly that comes from a patient being dehydrated, and that's not what we're going to discuss today. So far we learned the red blood cells, the hemoglobin, hematocrit. If any of those are low, that patient's anemic. We understand what each of those are, and we understand that the normal values for those are 5, 15, 45. let's go deeper into anemia labs, and let's start with reticulocyte. Reticulocyte is really more of an NP level lab. I just want to touch on it just for a second. Reticulocyte tells us how much production of red blood cells is going on. That's super important because we just said the most common cause of anemia is a decrease in red blood cell production, and another common cause of anemia is an increase in red blood cell destruction. So if I look at the reticulocyte count and I see that the retic count is high, that means that the body's producing a lot of red blood cells, so I don't have a problem with red blood cell production. And since it's producing a lot, it's probably because there's some red blood cell destruction going on. On the flip side, if I have a low retic count, that means the body is not doing a sufficient job of producing red blood cells, and I have a red blood cell production type of anemia. Next, we have the MCV. MCV is big Medsurg material. You absolutely need to know it. Normal MCV, which is mean corpuscle volume, and this is how big are the red blood cells. A normal MCV is 80 to 100. If the number is below 80, the red blood cells are small, and that's called microcytic. And if the number is over 100, the red blood cells are big, and that's called macrocytic. Very often on the chart you see on the bottom of your screen that I made, very often we're going to group anemias into microcytic, normalcytic, or macrocytic. You must know, again, that value 80 to 100. The MCH or the MCHC, you do not need to know at the RN level, but just in case you ever hear it, this is how we evaluate if a patient's red blood cells are hypochromic or normalchromic. Let's go ahead and start talking about our different types of anemias. I'm going to, again, focus mainly on the Medsurg core content, the stuff that you're going to see on the NCLEX, and I'm going to try to keep it as focused as possible. Starting with aplastic anemia. Aplastic anemia is bone marrow failure. Bone marrow is where we produce red blood cells. It's also where we produce white blood cells and platelets. If a patient has bone marrow failure, they're going to have a decrease in all of them. Not only are they going to be anemic, that they have a low red blood cell count, but they're going to have a low white blood cell count and a low platelets. That's called pancytopenia, when everything is low out of the red blood cells, the white blood cells, and the platelets. This patient not only is going to be anemic, but because of the low white blood cell count, they're also going to be immunosuppressed. And because of the low platelets, they're also going to be at risk for bleeding. So definitely make sure that on a test, you're cognizant of the fact that aplastic anemia is going to have all three of those issues. They're going to be anemic, immunosuppressed, and at risk for bleeding. Additionally, the treatment for aplastic anemia is going to be a bone marrow transplant. And that's going to be our only really definitive treatment to be able to fix aplastic anemia. Next, let's look at iron deficiency anemia. Iron deficiency anemia is the most common type of anemia in the United States, possibly the world, I'm just not sure, but definitely in the United States. The cause of iron deficiency anemia, also known as IDA, is going to be blood loss, and usually this is going to be a slow blood loss, such as a GI bleed or chronic vaginal bleeding from heavy periods. It could be from a lack of iron. The patient's just not getting enough iron in their diet, or it could be malabsorption where the body's not properly absorbing iron. The symptoms of this type of anemia are going to be your classic stereotypical anemia. This is going to be the fatigue. This is going to be where they're pale. This is going to be where they have exertional dyspnea and tachycardia, all the classic anemia signs and symptoms. The test that we use for this is called an iron panel. On an iron panel, we're going to check an iron level, which we would expect to be low in IDA. We're going to check a ferritin level, which we expect to be low in IDA, and we're going to check a TIBC. TIBC is total iron binding capacity, and the way I always think of this is how much shelf space is available for iron. Well, if I'm really low on iron, then there's a ton of shelf space available because the shelves are empty. So that's why the TIBC would be high. So if on a test, because this is fair game for RN level, if on a test, and for your Medsurg course for the NCLEX for all of it, if on a test you see a low iron, a low ferritin, and a high TIBC, that patient has IDA, iron deficiency anemia. How do we fix this? We treat the patient with iron. A few things about iron that hopefully you remember from your pharmacology course. I'm not going to go too deep into it, but remember in the liquid version, it stains teeth, especially in kids. So we have to keep it, we have to give it through a straw. This does have a black box warning to keep it away from children because it can cause fatal overdoses. Iron also is known to cause constipation. It can cause black stools. It is recommended to be taken on an empty stomach, and sometimes it's recommended to be taken with vitamin C containing juices such as orange juice to increase absorption. This is considered a microcytic anemia. Let's move on. The next one we're going to look at, going over to the other side of the screen, is going to be thalassemia. Here's another microcytic anemia. Thalassemia is a genetic type of anemia. There are two different types of it, alpha and beta. And this, since it has a very strong genetic component, it is most common in people of Asian, African, or Mediterranean descent. It is graded on a scale of minor, intermediate, and major. And in the problem in thalassemia is decreased hemoglobin production. This is again considered a microcytic anemia, and the treatment over here is going to be transfusions. And generally, these patients need regular transfusions throughout their lives. Any patient that gets frequent transfusions is at risk of developing iron problems of too much iron. Therefore, another key part of the treatment of thalassemia is what's called iron chelation, where we give the patient certain medications to bind to the iron in their body to get rid of it because they often end up with too much iron. That's thalassemia. Again, there's a lot more we could go into for this. There's different tests that we do for this. There's whether we're looking for alpha thalassemia or beta thalassemia. I think all of that's beyond what the RN level would be tested on. Let's move on down to B12 or pernicious anemia. Those both mean the same thing. B12 deficiency anemia or pernicious anemia is the same thing. This is from one of two causes. B12 or pernicious anemia can be because the patient's not getting enough B12 in their diet. That's not that uncommon. Why? Because all our sources of B12 come from foods that are restricted on a vegan diet. They come from turkey and other poultries. They come from meat. They come from fish, all things that you can't have on a strict vegan diet or vegetarian diet. Therefore, those patients are at risk for developing B12. However, B12 deficiency anemia is really uncommon due to dietary issues, and that's because so many foods today are fortified with B12, such as cereals, and a lot of the plant-based foods are fortified with B12 specifically because of the population that they're serving of vegan and vegetarians that they know are at risk of not having enough B12 in their diet. So that's B12 deficiency anemia. That's the first reason why a patient would develop it. But like we just said, because of the fortification of foods nowadays, that's uncommon. The more common type of common cause of developing pernicious anemia is where a patient is missing something called IF or intrinsic factor. Intrinsic factor is something we have in our body that helps us be able to use the B12 that we eat in our diet. If we don't have this, then no matter how much B12 we eat, our body cannot synthesize B12 and we end up B12 deficient. So that's the more common cause today of pernicious anemia. So what do we need to know about it? A few things. First of all, this is considered a macrocytic and megaloblastic anemia. So if you see that term megaloblastic anemia, it's talking about B12 anemia or folic acid deficiency anemia, which we'll get to next. Now, the few things that I see commonly tested on the Medsurg courses about pernicious anemia. First of all, the onset of symptoms is very slow. Generally 2 to 10 years it takes for the symptoms to develop. Second, pernicious anemia is the only type of anemia that is common to have major neurological symptoms. Why? Because one of the things the body uses B12 for is for the development of the myelin sheath that is around our nerves. And without B12, that doesn't get fully developed, so the patients develop neurological symptoms. Common neurological symptoms could be ataxia, which is difficulty with movement. They may end up with memory or cognition issues. They may end up with numbness or paresthesias. So all of those neurological symptoms should definitely point you towards pernicious anemia. Another big one that I see on tests is going to be glossitis. Glossitis is what's described as a big beefy tongue, and that's another sign of a patient that has B12 deficiency anemia. How is this treated? It's treated with a drug called cyanocobalamin, which is B12. Cyanocobalamin is famous in pharmacology world because it's actually a red liquid. Generally, if you see a red liquid in the vial you're about to give your patient, please throw it away. But in this case, that's actually appropriate. And also, this is IM injections that the patients get for the rest of their life. Now, some of the newer guidelines on how we treat patients with lifelong pernicious anemia is that we get them stabilized with their B12 and get rid of all the symptoms and get them their B12 levels 100% normal with the IM injections. And then there is the option to switch them to an oral method of cyanocobalamin or to an intranasal method of cyanocobalamin. I'm not going to get into that. For test purposes, it's still going to be lifelong IM injections of cyanocobalamin, which is usually every few weeks or maybe every month. Next, let's talk about folic acid deficiency anemia or folate deficiency anemia, same thing. And this is another macrocytic megaloblastic anemia, just like B12 anemia. And this one actually is common to go together with B12 deficiency anemia. When we talk about folic acid deficiency anemia, this is common from poor diet, such as a big one is going to be patients with a history of alcohol use disorder, because that causes a patient to have folic acid deficiency anemia. Pregnancy, breastfeeding, stages of growth where patients use a lot of folic acid is going to be another big risk factor for developing folic acid deficiency anemia. And then malabsorption, just like with iron. Another thing I probably should have mentioned earlier about iron as well as folic acid is iron and folic acid are the two core components of prenatal vitamins. If you remember from whatever class this would have been covered in, it could have been covered in OB, it could have been covered in fundamentals and pharmacology, but prenatal vitamins are recommended for all patients to take prior to attempting conception. The official recommendation is, I think, 30 days prior to trying to become pregnant, the female should start taking the prenatal vitamins. And the core part of prenatal vitamins is iron and folic acid. In fact, one of the drugs that we use to induce abortions is methotrexate, and methotrexate is a folic acid inhibitor, because folic acid is so crucial in embryo development, especially in the first few days and weeks of after conception. So folic acid is a really big part of that. So again, that's why it's a big part of prenatals and something that you probably have already learned as a recommendation for patients attempting conception. Next, folic acid, how do we diagnose it? By checking if the patient has a low folate level. I didn't mention this with pernicious anemia, but we could check for that if a patient has a low B12 level, and we could check for IF, that intrinsic factor antibodies. I don't think you can be tested on that on a Medsurg course, but just FYI. So back to where we were, folic acid deficiency. This is tested by a low folate level. Again, we already said this is a macrocytic megaloblastic anemia together with B12, and those two do go hand in hand very often. And this one's treated with folic acid supplements, pretty easily treatable. Next, we're going to talk about sickle cell disease. Sickle cell is a genetic disease, and it's a hemolytic anemia. It is a result, the patient becomes anemic as a result of destruction of the red blood cells. So what exactly happens here? First of all, when this is a genetic disorder that is by far most common in patients of African descent and African Americans. Now, the big problem in sickle cell is the patient has, under normal circumstances, everything's going fine. But when they are triggered, their sickle cell kicks in and they end up in what's called a vaso-occlusive crisis. A vaso-occlusive crisis is where the cells change and the cells become elongated. The red blood cells, they become elongated and they become sickle-shaped. And the term we use, they become sickled. And when that happens, they're in a vaso-occlusive crisis. These sickled red blood cells, A, they don't function properly. B, they have a major risk of aggregating and causing obstructions, and which cuts off blood supply. So it can cause basically clotting. Plus, it triggers inflammation. Both the inflammation and these cells getting stuck in different capillaries and different areas and causing an obstruction of blood flow, those two factors cause tremendous pain, which is usually what patients end up coming in for. So again, a vaso-occlusive crisis is where the normal red blood cells, they become sickled or elongated as a result of a trigger. The common triggers are going to be things like stress, dehydration, and infection, or patients exposed to cold. Now, one of the main things you're going to be doing as an RN in terms of sickle cell, especially for NCLEX purposes, is educating patients on avoiding their triggers. Next, we're going to talk about treatment. The treatment, if a patient does end up in a vaso-occlusive crisis, which these do happen to these patients, they understand this well, they know the routine. And in these cases, we're going to treat them with oxygen, especially if they're hypoxic. We're going to treat them with fluids to prevent dehydration. We're possibly going to transfuse them depending on how low their hemoglobin is. And we're going to give them opioids for pain. Now, I am going to give you a heads up here. These patients are going to look on the outside perfectly fine, and yet they're going to be screaming in pain. We do not decide what patient's pain is. If the patient's pain is at the level we're treating it with opioids, we treat it with opioids, whether we see it or not, whether we believe it or not. That's not for us to decide. Next, let's talk about anemia of chronic disease. This will be our last one. And in this case, this is anemia from some sort of other issue going on in the body. The other issue is generally going to be something like inflammation from rheumatoid arthritis or ulcerative colitis. It could be caused by an infection, or it can be caused by chronic kidney disease. Chronic kidney disease makes sense because you'll remember at the beginning of this video, we said that red blood cell production is stimulated by erythropoietin, which is produced by the kidneys. And if the kidneys are failing, they're not producing that erythropoietin, which stimulates red blood cell production. So that part makes perfect sense. Anemia of chronic disease is very common. I believe it's the most common cause of anemia in the geriatric population. The labs we would see on this one is going to be a normal ferritin, which is different than iron deficiency anemia, a low TIBC, which is different than iron deficiency anemia, and a low iron, which that one's the same as iron deficiency anemia. Don't get confused on a test. If you see low iron, that doesn't mean it's an iron deficiency anemia. You have to keep looking to see if it's iron deficiency anemia or anemia of chronic disease, especially since these are the two most common in the United States. They're definitely going to be the two, not definitely, but they're likely two of the most tested on ones for the NCLEX and for Medsurg. Now, how do we treat anemia of chronic disease? It depends on the underlying cause. But for testing purposes, the most common way that we're going to end up treating this is with erythropoietin. Remember, that's what we said the kidneys are used to producing. If the kidneys are failing and they're not producing them, the patient needs erythropoietin to stimulate that production of red blood cells. A few things about erythropoietin, if you remember from pharmacology. First of all, this has a black box warning that it can't be given to patients if they have a elevated hemoglobin level, or not elevated, a hemoglobin level above 11, because in that case, the patient will end up with too much RBCs, their blood will become too thick, and they'll be at risk of clotting. Also, please note that when we give a patient erythropoietin, it's going to take about 2 weeks for their RBCs to come up. So if the patient's severely anemic, they may have to get transfused in the meantime. Hopefully this covered everything that you need to know about anemias for your Medsurg course. If you have any questions, please reach out. Otherwise, do great in school and on your tests, and I'll see you in the next video.